Hello and welcome. I'm Carl Svedberg from the University of Gothenburg. This is EHJ Today, and I'm here in Chicago together with Dr. Anna Axelsson from Rikshospitalet in Copenhagen and Dr. Joanne Ashley from Stanford University. We're going to talk about a trial that Dr. Axelsson has presented here, the INHERIT trial. Now, Anna, tell me, what's the INHERIT trial about?
The INHERIT trial is a randomized trial where we investigated the effect of Losartan in hypertrophic cardiomyopathy.
So, what's the rationale for doing this?
Well, the rationale is that there is no medical treatment that has been demonstrated to alter the disease progression or outcome in hypertrophic cardiomyopathy. And as such, accordingly, the current treatment guidelines, they focus on the alleviation of symptoms. But some animal studies and also human pilot studies have suggested a beneficial effect of angiotensin receptor blockers on both hypertrophy and fibrosis and symptoms.
Is that something that with the background of the LIFE trial many years ago?
No, because the LIFE trial was a different population that was in hypertension. So these patients have the inherited disease, hypertrophic cardiomyopathy, where we don't know much about the disease mechanisms.
So, so what did you do? How did you do this trial?
Well, what we did was that we consecutively screened patients in our outpatient clinic, and we randomized 133 patients to Losartan or matching placebo, 100 milligrams for 12 months. And the primary endpoint was left ventricular mass, index to body surface area, which we assessed before and after treatment.
How? How did you assess?
It was assessed with MRI or in patients with ICD with CT. So we used two different modalities.
And well, then I understand. Otherwise, 130 patients doesn't sound a lot in this type of trial, but you used a sophisticated technique.
Yeah, we believe the trial had a good power to investigate what we wanted to, an effect on left ventricular mass, and it is the largest randomized trial in hypertrophic cardiomyopathy.
Okay, so what did you find?
Well, we found that both groups, both the Losartan and the placebo group, had a small decrease in left ventricular mass from baseline to follow-up, but there was no difference between the groups, suggesting that Losartan had no effect on left ventricular mass in hypertrophic cardiomyopathy.
So the between group, there was no
significant difference in between the groups, yes. And in addition, we saw no effect on any of the secondary endpoints, including maximal wall thickness, fibrosis, exercise capacity, and all the diastolic parameters.
So, in that sense, this was a very neutral results in general then?
We still believe that we learned some things from the trial. It is the first trial there have been some pilot studies before, but this is the first trial to include patients with obstructive physiology, having a gradient in the left ventricular outflow tract, which has previously been considered to be a contraindication. So, but the treatment with Losartan appeared safe in this group as well. So I think that is something important that we learned from this trial.
Okay, Dr. Ashley, you were discussant at after this presentation. What did you comment, and how did you interpret these findings?
Well, first of all, I'd like to say congratulations to Dr. Axelsson and her colleagues for carrying out a really important trial. As she mentioned, we do not have great therapies in hypertrophic cardiomyopathy, and really no randomized controlled trials have existed to date. So this was a really important trial to carry out. In particular, targeting the renin-angiotensin system is also something that has a great rationale from preclinical studies in mice and from cells, and from what we know about hypertrophy. So it was really important to do this, and I think it's very hard to do studies in rare disease, because this is a disease that's 1 in 500 in the populations that it's found in. So it's not one where you can go out and easily find patients. So congratulations to her and to the team on really performing and finishing a great trial. It's always disappointing if your primary endpoint doesn't meet the criteria that you were hoping for. But I don't think that this closes the book in any way on the idea of blocking the renin-angiotensin system for the treatment of hypertrophic cardiomyopathy. The studies that we have to date use drugs that don't even attack the fundamental basis of the disease. We use beta blockers, we use calcium channel blockers, really to aim, as she mentioned, at the symptoms of the condition. And many patients are not tolerant of those medications. So really, as a community, we're looking towards trying to find better therapies. And I think there's a few questions raised here. The first one is a really important one. We've always been wary of using vasodilators, even mild vasodilators, in patients with obstructive hypertrophic cardiomyopathy. Many of us do it because we know hypertension is by itself a major risk factor. And so the fact that they were able to demonstrate safety in this population is a first and an important contribution to the literature. But I think also then there's the question of whether LV mass is really the right target, and whether there are likely to be some important other effects that are significant and beneficial that we've seen in other trials of these sorts of agents that we just haven't been able to pick up with the technologies that we have at hand. MRI is certainly sensitive, but I think the challenge is how much of a change in LV mass would we expect. I think if we had a small change in fibrosis, even a small change in the underlying driver for the disease, then we might not be able to measure it, but it could still be very important.
So Anna, one question that would be one of the first, was the dose too low, or?
We gave 100 milligram Losartan for 1 year. It can also always be discussed if the dose should be higher, maybe 150. The pilot trials that have been carried out used either 50 or 100.
Yeah, but in heart failure it's been shown that 150 is significantly better than 50. And so that would have been one option. So what do you plan to do next?
Well, I don't have any plans for our study group, but I'm very much looking forward to the VANISH trial, for example, which is a trial of Losartan, also in hypertrophic cardiomyopathy, but in a slightly different population. Maybe Dr. Ashley can fill me in on that.
To mention, this is a trial that's being led by Carolyn Ho from Brigham and Women's Hospital, multi-center trial predominantly in the US of patients who are younger, between 8 and 30 years old, and including a set who are genotype positive and phenotype negative. So, but all patients in the trial will have either a pathogenic or likely pathogenic variant. And so I think that's a slightly more targeted group. It's a younger group. And it is a different agent. The sartans, of course, have clear class effects, but valsartan is potentially a little bit more.
What's the dose?
Potent in some ways.
What's the dose they use?
I don't know the dose.
Okay.
Yeah.
So, and then a potential next step. We have just discussed at this meeting, and actually in another discussion here, the agent Elsie said 696, which gives additional effects. So you might have to plan for such a trial in this where there is obviously an unmet need for this patient population. So that would be another possibility for the future, which could keep you busy.
I think so. We would all like a great new treatment for this disease.
So Anna, good luck with the future and your future efforts to improve the treatment for these patients.
Thank you very much.